Hello everyone, my name is Lexie and today I'm going to present my systematic review on the effectiveness of mesenchymal stem cells as a treatment for osteogenesis imperfecta by synthesizing and evaluating the biological workings behind and implications of mesenchymal stem cells when used in a clinical setting. To start off, what is osteogenesis imperfecta? Osteogenesis imperfecta, abbreviated to OI, is a heritable genetic disease caused by a mutation in the COL1A1 or COL1A2 gene, which controls type 1 collagen production. The rate of collagen production or the structure of collagen in individuals with OI is abnormal, resulting in bones that are more brittle. It occurs in 1 out of every 20,000 births, making it fairly rare. However, it is a very serious condition. While not immediately fatal, mortality among newborns with any type of OI is 126 times higher than that of the general population. Severe phenotypes of OI can even affect fetuses, calling for treatment as effective and early as possible. Current treatment of OI focuses on minimizing the likelihood of bone fractures and deformities. Some common treatments include increasing intake of vitamin D and calcium, going to physical and occupational therapy, and using bisphosphonate medication. However, these treatments don't effectively target the symptoms of OI. Namely, the effectiveness of bisphosphonate medication has been debated due to a number of contradicting studies on the effect of bisphosphonates on pain reduction, bone growth, and mobility in people with OI. The use of mesenchymal stem cells, abbreviated to MSCs, is one of the main ways that the regenerative technology used in OI treatment can be advanced. MSCs are able to differentiate into a variety of cells that are found in the fur bone. They aid in both the effectiveness and efficiency of regenerating bone tissue by being able to migrate to injured sites and secrete cytokines and growth factors to spur tissue regeneration. MSCs also have non-immunogenic properties, which allows them to be used by a variety of people and cause few side effects. Therefore, this systematic review aims to determine the potential for MSCs to be used as a treatment plan for patients with OI. This was done by examining certain aspects of bone composition of patients before and after MSC infusion. If successful, MSCs could offer a much less invasive and more effective method of treating patients with OI. This systematic review was conducted following the PRISMA guidelines to provide data that would help understand the effects of MSCs. All sources were derived from the ScienceDirect, Google Scholar, and PubMed databases. The search terms that were used included various iterations of osteogenesis imperfecta, tissue engineering, regenerative technology, and mesenchymal stem cell used singularly or in combination. Studies were included only if they addressed symptoms of OI and the use of stem cells for osteogenesis in bone affected with OI. Only publications in English were considered, and there was no limit regarding the year of publication. The search identified 801 unique articles. A total of 46 articles were selected for full-text screening and checked for eligibility. 29 studies were excluded for various reasons, some being incomplete studies or case studies, and others being irrelevant to the aim of the systematic review by addressing diseases with similar phenotypes but different genetic causes as OI. This resulted in 17 studies being included in the systematic review. On the right is the PRISMA flow diagram showing the systematic review filtration process. In people that have OI, the delayed maturation of bone tissue results in poor bone structure. To combat this, treatments should aim to increase bone mass and density. 3 studies reported increased bone mass and 5 studies reported increased bone density after MSC transplantation. Increasing bone mass and density reinstates a normal, healthy bone tissue environment. Increasing the collagen content of bone, and therefore its mineral content, is an effective way to target bone mass and density. 10 studies have shown increased mineralization of bone in people with OI after MSC transplantation. 4 studies have also reported increased collagen amounts after MSC infusion. This provides proof of MSC differentiation into mature osteoblasts, which produce COL1A2 protein. This is significant because COL1A2 protein is absent in OIM mice, which have the same biochemical and phenotypic features of human OI. Therefore, the infusion of MSCs effectively makes up for the genetic defect. By being able to produce COL1A2 protein, the need for other medications like bisphosphonates would be reduced or even eliminated, and future fractures can be prevented. The resulting fracture rates of patients after MSC transplantation demonstrate the effects of increased bone mass, density, and mineral and collagen content. 7 studies have shown a decrease in fracture rates after MSC transplantation. One patient even went 2 years without any new fractures after MSC transplantation, in contrast to the 20 fractures she suffered in the 6 years prior. It's important to note the amount of time until MSCs start to take effect. 5 studies report bone growth acceleration after MSC transplantation. One study mentioned a marked 60 to 94% increase in growth velocity within 6 months after MSC transplantation, demonstrating how quickly treatment will work. However, just because treatment works quickly does not mean it's less effective. The quality of osteogenesis induced by MSCs was high. One study using OIM mice demonstrated well-developed bone and a large vasculature network in bone defects. Accelerated quality bone growth can not only act as a preventative measure against bones regrowing in the bone structure, but also shorten the time frame in which weaker bone is more prone to fracture. One of the biggest advantages to using MSCs for stem cell therapy is their ability to differentiate and migrate. 4 studies have demonstrated MSC's successful differentiation into osteoblasts. This allows for a greater number of osteoblasts to produce COL1A2 protein, as well as a variety of cells found in mature bone, like cartilage, fat, and neurons, which causes bones to become more stiff, reducing the chance of fracture. Intravenously infused MSC demonstrated site-specific differentiation, which allows MSCs to be used in a wide range of bone fractures and defects. Site-specific differentiation occurs after MSCs migrate to the area in need of healing. MSCs were particularly detected at sites of bone remodeling and fracture healing, demonstrating high migration ability. One study observed that proteins involved with cell migration were increased 9-fold. Because of MSC's ability to migrate, the need for more invasive procedures can be reduced or even replaced with intravenous infusion while providing similar clinical benefits. Another major advantage for using MSCs is how widely applicable it can be to immunocompetent organisms, even if they aren't immunosuppressed. 7 studies reported that MSC infusions and transplantations were well tolerated, eliciting no symptoms that indicated a rejection of donated cells. Transplantation of MSCs into a fetus was tolerated well by both the fetus and pregnant woman, showing potential for MSC treatment to be started before birth. However, the lack of an immune response does not mean that there were no clinical benefits, as engraftment and integration of MSCs was confirmed in a patient whose immune system was not suppressed. Despite MSC's proven effectiveness at treating OI, there are still several disadvantages to using them. The severity of OI that an individual has may also affect the efficacy of the hormone signaling response induced by the MSCs. Additionally, despite MSCs being non-immunogenic in nature, a significant association between MSC infusion and fever has been observed, and proteins involved with the inflammatory response were increased 9-fold after MSC infusion. The largest disadvantage for implementing stem cell therapy is that the clinical benefits of MSCs fade quickly. 6 studies have reported the effects of MSCs fading, resulting in slowed or plateaued growth rates, increased rate of fractures, and the decline of some bone parameters after a period without reinfusion. Because of this, repeated infusions are necessary to keep the patient's bones strong. This can pose both a health risk as well as an inconvenience for patients. Moving on to the limitations of this systematic review. The main limitation of the systematic review was the time period that the studies were conducted for, as well as the limited number of study candidates. The longest study with repeated MSc infusions was only 2.5 years long, so reliance on MSc infusions for an indefinite amount of time may result in unforeseen side effects. Additionally, one study implemented very restrictive inclusion criteria, causing them to find only 2 suitable candidates. Some may also be uncomfortable with the origin of the MSCs used in treatment due to their personal beliefs and therefore choose not to receive the treatment, as some MSCs are derived from women who chose to terminate their pregnancy and donate the fetus's cells. This may have caused the conclusions reached in the studies to be less generalizable. This systematic review highlights the biological workings of mesenchymal stem cells, investigating their potential as a tool for medical providers to use when considering patients with osteogenesis imperfecta. The benefits of MSCs as a treatment for OI have generally been positive, allowing the symptoms of OI to be combated effectively and efficiently through their biological capacity to differentiate and migrate. However, further research needs to be conducted to investigate potential methods that can prolong the positive effects of MSC treatment. That is all I have for you today, and thank you so much for listening.